Hello, welcome to this lecture. My name is Nikki Campbell and I'm absolutely delighted to be here with you. The topic of our lecture today is cochlear implant candidacy. The aspects that we'll be looking at is why do we have these criteria? What are the candidacy criteria across the world? We'll be looking at some of the guidance from manufacturers, and more specifically we'll see what is happening in particular countries. We'll be focusing on the UK, which is where I am, and of course it's important to consider what is happening in China, which is where you are. And finally, we'll be looking in terms of some of the main evolving candidacy criteria that are changing and why this is changing. Okay, so why do we have candidacy criteria? Let's pause for a moment for some thought. Right, you may be thinking that it's really important for us to ensure that when we give a cochlear implant that we're doing the best possible thing for that individual with a hearing impairment. Perhaps you've even thought of funding, that you've thought that it's really important that if we're spending quite a bit of money on a cochlear implant, we want to make sure that that money is justified. It's important to recognize that these criteria are based on research evidence, and they need to be amended and updated as our knowledge of this topic increases. When it comes to funding, we need to consider that funding comes from different avenues. In the first instance, it might be self-funded. In other words, the person is paying for their own cochlear implant, and they need to be sure that the money that they are spending is well spent. Similarly, in some cases, it might be state-funded. In other words, a national health system that is covering these costs. They too will want to make sure that the costs are justified. And in some instances, there may be medical insurance as well. Okay, so let's have a look at what's happening around the world and what the manufacturers are recommending. Well, if we look in terms of the manufacturers, interestingly enough, when you've paged through all of the documents, and I've given you the links that are available here for you, it's really interesting to see the commonality and the similarity between the recommendations. In a nutshell, cochlear implants are recommended for individuals who have a hearing loss in both ears, where the hearing loss is severe to profound in nature. What does differ slightly is the cutoff where we should be considering cochlear implantation in terms of the audiogram. And there are also differences with regards to which speech perception tests we should be using. And this indeed reflects what is happening in different countries and indeed in different centres. I'd like to share with you a really good study, and I've given you the reference at the bottom of the screen. It's a very recent study that's just been published by Debbie Vickers and her colleagues. And what they did was they compiled an online questionnaire that they sent to 25 countries and invited them to take part. 18 of these countries responded. And what they did was to inquire about what is happening with regards to cochlear implants in these various countries. What are the candidacy criteria that are being used? And there were some really interesting findings. Looking in terms of funding at all of these different services across the world, 60% of the funding is national. 30% comes from medical insurance, and 10% of people choose to self-fund a cochlear implant either for themselves or for their child. Not unexpectedly, we find that state funding is less available for those adults who are wanting 2 implants. So there's general consensus amongst funders that they're willing to fund for a child for 2 implants, but some reluctance to give adults 2 implants. And we may wonder what the reason is for this. Well, in essence, we know with children are still acquiring speech and language, they're needing to progress at school, so that's perhaps the reason why children are favoured above adults. That said, it's really important for adults to also benefit from binaural hearing. In countries that use the pure tone audiogram to determine candidacy, 70 to 80% of the countries use the guidance of about 75 to 85 dBs in the frequency range above 1000 Hz. For countries that use speech-based adult candidacy criteria, they look in terms of, or the majority of people are using word tests. In other words, 40% of the countries are using word tests. 24 are using speech tests. And then there's a mixture of 36% that are using both. And that's really interesting to find out that the speech perception measures that we're using across the world differ to such a degree. Interestingly enough, the UK, where I am, and Belgium are the most conservative countries. In other words, the state funding available for cochlear implants is much more strict, much more restricted. Australia, Germany and Italy are far more lenient, and in a moment we'll see where China fits in relation to other countries. Interestingly enough, the self-funded services in all countries tend to be the ones that show greater flexibility when it comes to criteria. Okay, so time to have a look at what's happening in the UK. Well, in the UK, what we use is the guidance from the National Institute for Health and Care Excellence. And this is abbreviated to NICE. So when we talk about the NICE guidelines, it doesn't necessarily refer to good or bad guidelines, but rather this particular institution. In the UK, children and adults are eligible for a cochlear implant if their hearing on an audiogram is greater than or equal to 90 decibel at 2 and 4,000 Hertz. And this, of course, needs to be present in both ears. For adults, there's an extra criteria that they need to have a BKB score of less than 50%. Now, if you're unfamiliar with what the BKB sentence test is, this is simply a test which uses sentences and sees what the person is able to hear without lip reading when these sentences are presented. In the UK, it is essential that individuals are assessed by a multidisciplinary team, and it is recommended that both electrophysiological and behavioural measures are used. In the UK, children are allowed to have 2 implants, but this needs to be done simultaneously. In other words, the implants need to be done at the same time and in the same theatre session. And the reason for this is related to costs. It's more expensive to organise 2 different hospital visits and programming sessions, etc. So it's a way of reducing that cost. Unfortunately, adults in the UK can only have 1 implant, unless, of course, they've got blindness or very severe visual impairment or another disability that increases their reliance on auditory stimuli. It's essential before cochlear implantation that people have a trial with hearing aids to see how they get along and if that isn't a better alternative. Interestingly enough, for individuals with meningitis, these cases are fast-tracked. The reason for this being that there is ossification or hardening within the cochlea. So if that hardening has taken place, it's very difficult to get an electrode array in, and we find that the outcome is simply not as good. Now, what happens in the UK where we've got an exceptional case, where the person doesn't meet criteria, but they're really struggling and there's a really good case to be made for that person to have an implant? Well, we've got something called the individual funding route that people can apply through. But obviously at this current time, the UK, like so many other countries around the world, doesn't have a lot of excess money, so the applications are often not very successful. In terms of the services in the UK, I thought it might be of interest for you to note that we have 21 NHS services. So in other words, those are services that are funded by our national healthcare system. We have 2 private services, the first being Portland, which accepts referrals from overseas as well as people living locally. And then we've also got a self-funded service here at the University of Southampton, where I work. We have an NHS service here, but alongside that, I also oversee the self-funded service. Okay, so time for you to think a little bit. I've been doing a lot of talking. What I want to know from you is, what are the candidacy criteria in China? Also, how do these criteria compare with the rest of the world? Okay. In China, a division is made between prelingual hearing loss and postlingual hearing loss. So in other words, hearing loss that has occurred before language is acquired and hearing loss that occurs after language is acquired. In terms of prelingual hearing loss, there are very nice, clear directions in terms of electrophysiological test results as well as behavioural test results. And I think these are really important because we know that with children, for example, can't always give a very accurate response with behavioural testing. So the electrophysiological measures assist us with this. And as you can see from the different measures there, what we're really looking at is a hearing impairment that shows as being greater than approximately 90 to 100 decibel. And then there's the question of when autoacoustic emissions, or OAE, are absent, we need to consider the possibility of auditory neuropathy. And I'll be saying a bit more about auditory neuropathy in a moment. As you know, with auditory neuropathy, we have ABR results which can be absent or abnormal, and we find that cochlear microphonics are present. Autoacoustic emissions may also be present, but sometimes these disappear, especially after someone has worn hearing aids for a period of time. In terms of the behavioral testing, we find that without hearing aids, the requirement is a threshold of greater than 80 dB for 5,000, 1,000 and 2,000 Hertz. There is also a criteria for with hearing aids, and then finally, as you can see, speech recognition scores looking at disyllable words, so in other words, words with 2 syllables like rainbow, that you need to have a percentage of less than 70%. This, of course, is quite similar to postlingual hearing loss, where we find that without hearing aids, a similar criteria of greater than 80, and again the speech recognition rate of less than 70%. So how do the criteria in China compare? Well, they compare very favorably. We find that the criteria in China are a bit more on the lenient side, so they're more on the side of Australia, Germany and Italy, in comparison, as I say, to the UK and Belgium, where the criteria tend to be a bit more strict. Okay, so now we get to the exciting part. So what's happening at the cusp of new developments and changes that are taking place? And here we find that there are changes around electroacoustic stimulation. There are changes with regard to ANSD, or the auditory neuropathy spectrum disorder. We're looking in terms of single-sided deafness and also using cochlear implants for tinnitus management. So let's look at all of these in a little bit more detail. Electroacoustic stimulation, or the hybrid cochlear implants, combine 2 technologies. It combines a cochlear implant with a hearing aid. The cochlear implant helps to give information about the high frequencies, and the hearing aid component helps to give information about the low frequencies. And these 2 technologies are combined into one particular device. As you can see on the slide here in the top right-hand corner, we've got the latest EAS device that is available by Medel, and you can see how it's integrated into this one device. If you look at the bottom of the screen, I make reference to video 1, and this is a very helpful video from Medel, which gives an understanding of how the system works. In terms of the criteria for when we consider electroacoustic stimulation, you can see on the audiogram the range that is indicated in purple. So the person's hearing thresholds need to fall comfortably within that range. And in a nutshell, what we're looking for is thresholds of 65 dB or better for the frequencies 250 and 500 Hertz. Other companies also have EAS options. What's vitally important with EAS is that we need to counsel patients appropriately. The new electrodes that we have are very, very good, and they result in very little trauma when inserted in the cochlea. So this is a significant improvement that has taken place in recent years. But even with that, we can find that there's a drop or a deterioration in hearing. So someone that appears to be a good EAS candidate before surgery may not preserve that residual hearing. If they do preserve that residual hearing, they can go ahead with EAS. If not, we can look in terms of the conventional standard cochlear implant. But often patients are disappointed because they've got an expectation. And really what we need to say is that the outcomes with cochlear implants are very good. The EAS offers a little bit more, but those are advantages that we can perhaps try and recover in a different way. So what are the advantages of EAS? Well, first and foremost, it certainly helps with music perception. Low frequency information sounds much more natural. It leads to improvements with pitch perception, with timing, hearing intonation in speech, and also speech perception in noise. And as I've mentioned before, The newer EAS systems have been designed in such a way that if the residual hearing drops, we can then swap over to the standard cochlear implant. And the new design in the electrode arrays has greatly improved. In the past, they were shorter, which was the way that we could preserve the low-frequency residual hearing, which meant that if the hearing went in that area, the electrode array wasn't anywhere near that area in the cochlea. So it meant that the person lost that range. The electrode array these days goes a bit deeper and covers that area and can be used in different ways. It can be switched on or off, and that is a significant breakthrough recently. So the next condition that I would like us to have a look at is the auditory neuropathy spectrum disorder. And this is something when I started in the field about 30 years ago and with cochlear implants, I've been very fortunate to be part of this journey right from the beginning. We didn't know about ANSD. We knew that there was something that wasn't quite right, but we weren't sure what was going on. And still, our knowledge of auditory neuropathy spectrum disorder, although greatly improved, provides us and yields a lot of questions, unanswered questions. Our best knowledge at the moment is that ANSD is caused by a problem in one of the following areas. And in essence, to break this all down very simply, it's a problem that's in the hair cell or with the synapse and the junction with the auditory nerve or the early part of the brain stem. So something is not quite right there. And with time, we'll find that the diagnostic procedures that we use will be finer and better in terms of teasing out where the problem is. And it's likely that it will be slightly different for different people. The diagnosis, as I mentioned, is somewhat tricky. What can happen is that we can have audiogram thresholds that can vary from normal hearing to profound hearing loss. And it's well known that the audiogram tends to fluctuate, so you may want to exclude the possibility of a functional hearing loss or someone feigning hearing loss. But at the same time, you do need to recognize that sometimes for people with ANSD, they have no control over that, and it may fluctuate from session to session. To make the diagnosis, we need to have, as I've mentioned, absent or abnormal ABR and present cochlear microphonics. Autoacoustic emissions may be available or may occur in some instances, but they often have disappeared, as I say, after using powerful hearing aids. So what do we do with children and adults with auditory neuropathy spectrum disorder? Well, they may or may not need intervention. So watchful waiting is a very important approach to these individuals. There is some evidence to show that there are individuals that benefit from standard hearing aid use, and if that is the case, then that's good. They don't need to undergo surgery. And what is very, very important, particularly in children, is to closely monitor their speech and language development, and based on that to make a decision around whether to consider a cochlear implant. So the NHS guidance that we have, that's the state guidance in the UK, is that we repeat the ABR at 9 months and we consider the corrected age if the child, for example, was born prematurely. It's really important that watchful waiting and to carefully monitor the progress of the individual. And then the very earliest age that we would consider cochlear implantation is after 15 months. The question arises, what about the individual funding route? And with the knowledge that we have with regards to ANSD, we no longer in the UK have to apply through this particular route. We can simply apply directly from funding, even although someone with ANSD's audiogram may not necessarily meet the standard criteria. Okay, and this is the area which is really groundbreaking, is in terms of single-sided deafness. So in other words, the person has completely normal hearing on one side and then a severe or profound hearing loss on the other side. In the past, we just accepted that someone had enough hearing in one side that they would be fine. But with the recent technology, questions are now starting to arise in terms of, isn't there an advantage to having that hearing in both ears? And what I've got for you in video 2 that you'll see, which is another MED-EL video, shows a lady who had single-sided hearing loss, as I've described, who was a musician. And she was finding it increasingly difficult to be able to do her work and to do her job. And she talks a bit about her experiences with a cochlear implant. What can occur in this type of situation as well is that if someone has single-sided deafness, they may have really bad tinnitus or ringing in that ear. So that can really disturb them. It has an impact on their emotional well-being, on their day-to-day functioning, and it can interfere with the hearing on the good side. So there is some research that is taking place now to look in terms of, is this a good treatment for managing that type of tinnitus? So, closing and bringing this all to an end, what have you learnt in this lecture? Well, we've realized that cochlear implant criteria are there to guide us so that we can make the best possible decision for an individual, and that we need to consider funding. We know that manufacturers offer guidelines, but even despite that, there are different criteria around the world and in different countries. There is similarity between these criteria, but there are some countries that are more lenient than others. And we've also had a look in terms of some of the new emerging areas with regards to the main evolving candidacy criteria and future directions. Thank you for listening to this lecture, and I wish you every happiness and success in your journey with cochlear implants. Thank you.